Good morning. Today's topic is about myopia. Myopia is one of the refractive errors. So, what are the three main refractive errors? Myopia, hypermetropia, and astigmatism. So, today we will see about myopia in detail. First, we will note about what is emetropia. So, when parallel rays of light coming from infinity or focused in sensitive layer of the retina with accommodation being at rest, it is called emetropia. So, usually from infinity, it should be focused on the retina. Components that maintain emetropization are axial length and then anterior chamber depth and corneal curvature. Okay. Coming to ametropia, so parallel rays of light coming from infinity with accommodation at rest or focused either in front or behind the retina. So further it is classified into myopia. In myopia, the parallel rays of light coming from infinity or focused in front of the retina. In hypermetropia, the parallel rays of light are focused behind the sensitive layer of the retina. And in astigmatism, the refraction varies in different meridia. So these are the types of ametropia. In myopia, it is in front of the retina. In astigmatism, you have two focal points. Two focal points which are different in different meridian. In hypermetropia, it is focused behind the eyeball. So coming to the main topic, myopia. Myopia or short-sightedness is a type of refractive error in which the parallel rays coming from infinity are focused in front of the retina with accommodation being at rest. So this definition is important. Coming to optics of myopia, the optical system is too powerful for its axial length. Okay. So the image of the distant object on the retina is made up of circle of diffusion formed by the divergent beam. Since parallel rays of light coming from infinity are focused in front of the retina, and the far point is the finite point in front of the eye. So the nodal point is further away from the retina, and the accommodation in uncorrected myopes is not developed normally. So they may suffer from convergence insufficiency, exophoria, and early presbyopia as they grow. Coming to image formation, in myopia, image formed in front of the eye, which is corrected by placing negative lenses. Okay, so whichever is formed in front of the eye, we place a negative lens, and hence it is focused on the retina. This is concave lens. So concave lens is placed and it is focused behind the retina. Okay. Coming to types of myopia. So first classification is based on etiological. Coming to axial myopia, result from increase in the anteroposterior length of the eyeball. And curvatural myopia, it occurs due to increased curvature of the cornea or lens or both. Index myopia, it is an increase in the refractive index of crystalline lens associated with nuclear sclerosis. So it occurs in cataract, mainly it occurs in cataract, okay, index myopia. And myopia due to excessive accommodation occurs in patients with spasms of accommodation. So these are the etiological classification. You have axial myopia, curvatural myopia, index myopia, and myopia due to excessive accommodation. And types of myopia continued. In clinically, we classify it into congenital myopia, which is present at birth, okay, and simple or developmental myopia, pathological or degenerative myopia, and acquired myopia. In congenital myopia, it is present since birth, seen more frequently in children who were born prematurely or with various birth defects. Okay, usually the error is about 8 to 10 diopters, which mostly remains constant. Maybe sometimes be associated with other congenital anomalies such as cataract, microphthalmus, aniridia, or megalocornea. So usually it is around 8 to 10 diopters. Early correction is desirable to help the children to develop normal distance vision and perception of world. So full cycloplegic refractive error, including any astigmatic correction, should be prescribed. Coming to simple myopia, it is otherwise called as physiological or school myopia. Physiological error, it is not associated with any disease of the eye. Coming to the etiology, it may result from normal biological variation in the development of the eye. Again, simple myopia, it is classified into axial or curvatural. So in axial, it is physiological variation in the length of the eyeball. In curvatural, it is due to the curvature of the cornea. The other features are role of diet in early childhood and theory of excessive near work. Coming to the clinical pictures and symptoms, we have poor vision for distance and asthenopic symptoms. It is eye strain due to dissociation between convergence and accommodation, may develop convergence weakness and exophoria and suppression in one eye. It can change the psychological outlook. And this is a table showing rough estimate of the visual acuity. The degree of the myopia is compared with the visual acuity. Usually, if it is the vision is around 6.9 to 6.12, it will be around minus 0.5 diopters. When it is around 6/18, it is -1. And when the vision is 6/24, it is -1.5. When it is 6/36, it is -2. And 6/60, it is -3. 4/60, it is -4. 3/60, it is -5. And 2/60, it is -6. Usually, this is a rough estimate. And this is not accurate. Like if it is 6/18, it should be -1. It is not like that. It is a rough estimate of visual acuity. Coming to the signs, signs means what are the signs in the eye? Usually the eyes are large and prominent, and there will be the anterior chamber will be slightly deep. Coming to the fundus is usually normal. Rarely temporal myopic crescents may be seen, and usually error does not exceed 6 to 8 diopters. And diagnosis is confirmed by performing retinoscopy. Okay. Coming to pathological myopia, it is a rapidly progressive error resulting in high myopia, usually apparent during the first decade of life, characterized by increase in volume of the posterior segment. Etiology, you have no satisfactory hypothesis has emerged to explain the etiology of pathological myopia. However, it is confirmed that genetic factors play a major role in the pathological myopia. It is said that increased axial length, degenerative changes in the retina and vitreous, and pathological complications are determined by different genes. Inheritance can be autosomal dominant, autosomal recessive, or X-linked. So this is one of the mechanism proposed. Okay. So in genetic factors play a major role. So there is more growth of the retina. When there is more growth of the retina, there is stretching of the sclera, which these both more growth of the retina and stretching of the sclera leads to increased axial length. And there occurs degeneration of the choroid and degeneration of the retina and degeneration of the vitreous. These are the features of pathological myopia, which forms the features of pathological myopia. In elongation of the eyeball, so it is this diagram shows elongation of the eyeball posterior to the equator in the pathological myopia. That is why stretching of sclera and sketching of choroid and retina are present. Okay. And coming to the symptoms, you have defective vision, muscae volitantis, and night blindness. And signs, the eyes are prominent, appearing elongated and even simulating an exophthalmos, and cornea is large and anterior chamber is deep. So pupils are also larger, and refractive error increased by as much as 4 diopters yearly and stabilizes at the age of 20. but occasionally may progress until mid-30s and frequently results in myopia of 10 to 20 diopters. So usually it is very high myopia of 10 to 20 diopters. Coming to the retinal changes in pathological myopia, what are the changes which are appearing in the optic disc? Optic disc usually appears large and pale. Usually it will be very large. At the temporal edge, a characteristic myopic crescent is present. The degenerative changes in retina and choroid are common. It occurs as a tigroid appearance of the fundus. We call it as tigroid fundus due to diffuse attenuation of the RPE. RPE is retinal pigment epithelium with visibility of the large choroidal vessels. Otherwise, we call it as tessellated appearance. Okay. Then coming to the Foster Fuchs spots, it may be present at the macula. So actually what are Foster Fuchs spots? It is a raised circular pigmented lesion developing after subretinal hemorrhage has been absorbed. In advanced cases, there occurs focal chorioretinal atrophy, which is characterized by visibility of the larger choroidal vessels and eventually the sclera and total retinal atrophy, particularly at the central area. There may be associated lattice degeneration or snail track lesions. Retinal tears, hemorrhages, retinal detachment may be seen. A posterior staphyloma is an ectasia or bulging of the posterior sclera due to focal expansion and thinning. It occurs in about 1/3 of the eyes with pathological myopia and is virtually always peripapillary or involves with the macula. Staphyloma development can be associated with macular hole formation. So after retina, we come to the vitreous. So what are the degenerative changes of the vitreous? It includes liquefaction, vitreous opacities, PVDs appearing as vis reflex. Visual field shows contraction and sometimes ring scotoma may be seen. So mostly the changes are present in retina, choroid, sclera and vitreous. So vitreous liquefaction, opacities and posterior vitreous detachment. So that we call it as a vis reflex. So this is the diagram showing fundus changes in myopia. You have a choroid and sclera, which forms the temporal myopic crescent. And this is the retina, pigment epithelium, choroid and sclera. So you have a temporal myopic crescent. This is the typical. And this picture shows the macula having the Foster Fuchs spots, okay, and macular degeneration. So macula, there is a degeneration and reddish elevated spot, which is called as Foster Fuchs spots. High myopia also have peripheral retinal degenerations due to stretching of the sclera. So here are few peripheral retinal degenerations shown in the picture, like lattice degeneration, snail track degeneration, and this is acquired retinoschisis, and this is white without pressure, and E is a focal pigment clumps, and diffuse chorioretinal degeneration or peripheral cystoid degeneration. So most common is lattice and snail track degeneration. And coming to choroidal neovascularization, it is associated with the Lacquer crack and present in high myopia. And present in high myopia. So Lacquer cracks are also features of high myopia. So these are the cracks in the choroid. Coming to the complications of pathological myopia. So what happens when the sclera and choroid are stretched? So one is rhegmatogenous retinal detachment, which is more common in high myopia. The pathogenesis including increased frequency of posterior vitreous detachment, lattice degeneration, asymptomatic atrophic holes, macular holes, and occasionally giant retinal tears. Foveal retinoschisis and macular retinal detachment without macular hole formation may occur in highly myopic eyes with posterior staphyloma, probably as a result of vitreous traction. And then comes complicated cataract, maybe either posterior subcapsular or early onset nuclear sclerotic. And sometimes there may be nuclear sclerosis or vitreous hemorrhages or choroidal hemorrhages and thrombosis. And then comes your primary open angle glaucoma. And systemic associations. So till now we saw the ocular associations. Systemic associations of high myopia include Down syndrome, Stickler syndrome, Marfan syndrome, prematurity, Noonan syndrome, Ehlers-Danlos syndrome, and Pierre-Robson syndrome. Coming to acquired myopia. So we finished pathological myopia. This is acquired myopia. The causes include index myopia seen in nuclear sclerosis and incipient cataract. Diabetic myopia occurs due to decrease in the refractive index of cortex. Curvatural myopia, it is due to increase of corneal curvature in diseased conditions like corneal ectasias and conical cornea. And positional myopia, it occurs due to the conditions producing anterior subluxation of the lens. Okay. So these are the causes of acquired myopia. So what is consecutive myopia? Surgical overcorrection of hypermetropia, pseudophakia with overcorrecting. So whenever we keep overcorrecting IOLs, it leads to consecutive myopia. And pseudomyopia, it is also called as artificial myopia. It is produced in conditions such as excessive accommodation and spasm of accommodation. It may develop after two full hypermetropic correction in children. And pseudomyopia correction, cycloplegic refraction, always prescribe plus lenses. Okay, so it is cycloplegic. We put the cycloplegics, then we do retinoscopy, and then we prescribe the plus lenses. Coming to space myopia, it is experienced when the individual has no stimulation for distance vision, but it is never more than 0.75 to minus 1.5 diopters. Night myopia or twilight myopia, it is when there is a shift from photopic to scotopic vision at twilight. There is increased sensitivity to shorter wavelength of light, and the middle range of visual spectrum will be slightly myopic for the shorter wavelengths. Acquired myopia, in one more thing is drug induced myopia. So which drugs? Usually cholinergic drugs such as pilocarpine, ecothiopate, diisopropyl fluorophosphate, and sulfonamides, usually they cause myopia, which is called drug induced myopia due to pupillary constriction. So pilocarpine will cause pupillary constriction. Coming to treatment of myopia, so myopia is refractive error. So we have optical treatment, surgical treatment, general measures, visual hygiene, and low vision aids. Coming to optical treatment, it includes prescription of the appropriate concave lens with minimum acceptance, providing maximum vision should be prescribed, and we never overcorrect the myopia. This is one of the guidelines for correcting low degree of myopia up to 6 diopters. So usually children younger than 8 years should be fully corrected and instructed to use their glasses constantly. And adults younger than 30 years usually accept their full correction, and older than 30 years are not able to tolerate. So we can little bit less correct, okay, than the full correction with which the patient is comfortable. And guidelines for correcting high myopia, we have full correction can be rarely tolerated. So we can little bit undercorrect compatible with comfort or binocular near vision. Undercorrection to the tune of 1 to 3 diopters or even more may be required. So undercorrection is always why better means to avoid the problem of near vision, and the image will be minified. So to prevent that, we usually go for little bit of undercorrection. So how to prescribe the concave lenses? You can give spectacles or contact lenses, whichever the patient requires. So this is the correction diagram with concave lenses. Coming to surgical treatment. Surgical treatment, one is radial keratotomy. So it is making deep 90% thickness radial incisions in the peripheral cornea, leaving about 4 mm central optical zone. On healing, flattens the central cornea and thereby reducing the refractive power. Refractive error is between -1.5 to up to -6 diopters. We can correct with this. So this is radial keratotomy. And photorefractive keratectomy. So it is photo ablation of excimer laser, which can be accurately ablate the corneal tissue to an exact depth with minimal distortion of normal tissues. And myopia is treated by ablating the central anterior corneal surface so that it becomes flatter. So usually what they say is approximately 10 micron of ablation corrects 1 diopter of myopia. Coming to LASIK, so what is LASIK? LASIK is laser in situ keratomylesis, and currently it is the most frequent performed refractive procedure, and it can correct the myopia of up to -10 diopters. Automated microkeratomes is used to raise the corneal flaps, and excimer laser is applied to the stromal bed, and flap is again repositioned. So this completes your surgical treatment. And then coming to the general measures, usually we give balanced diet rich in vitamins and proteins and early management of associated debilitating diseases. Visual hygienes, usually we advise visual hygienes also to avoid asthenopic symptoms, like adequate illumination to during the close work, and the print should be very clarity or visible, and it should be good to avoid undue ocular fatigue. Coming to low vision aids, it is so when low vision aids like magnifications, lenses or something like that. Usually it is indicated in patients of progressive myopia with advanced degenerative changes where useful vision cannot be obtained with spectacles and contact lenses. So usually in very poor prognosis, we go for low vision aids. So this is about myopia. Thank you.